11 psychotherapy ideas that hurt more than help. Hi everyone, and welcome to Psychotherapy Education and Training. I'm Dr. Steve Johnson, and if you're a therapist, psychologist, counselor, or just someone passionate about how people heal, you're in the right place. Today's topic is likely to challenge you, maybe even provoke you, and you may strongly disagree, and that's the point. We're talking about 11 popular psychotherapy ideas that may actually get in the way of helping clients. These aren't fringe ideas. They're common in training, supervision, and social media, but we need to think critically about them, whether we agree with them or disagree with them. Before we dive in, don't forget to like, subscribe, and leave a comment. I'd love to hear your thoughts, especially if you've run into these ideas in your work or had to unlearn them. Let's get started. 1. Validating all emotions. Validation is important, but not all emotions need to be validated. Some emotions stem from irrational beliefs, misinterpretations, or unhelpful assumptions. Validation without challenge can reinforce unhelpful patterns. Therapist. It's totally valid to feel that way. Of course, you're furious your coworker got a promotion, but the client didn't apply, has distorted expectations, or misread the situation. Alternative statement. Let's understand where that anger is coming from. Sometimes our feelings are definitely real, but not necessarily helpful or proportionate. 2. The vague idea of toxic relationships. Toxic is often used as a shortcut for complexity. Instead of labeling someone or a relationship as toxic, we need to look at specific behaviors, patterns, needs, desires, and boundaries. Vague labels shut down reflection and nuance. Client: my mom is toxic. I just can't deal with her anymore. But upon inquiry, it's occasional criticism and unmet expectations, not chronic harm. Alternative statement. Let's unpack what specific behaviors are painful and why. What patterns are showing up and how do you respond to them? 3. Attachment styles over symptoms. Attachment theory can enrich our understanding, but when attachment styles become the framework instead of the symptoms, we may end up treating labels instead of what's bringing the client in: anxiety, panic, depression, intrusive thoughts, or destructive behavior. Therapist: you're feeling anxious because you have an anxious, preoccupied attachment style. Instead of addressing current panic symptoms, avoidance behaviors, or cognitive distortions. Alternative statement. Attachment theory gives us some background, but what's happening in your body and thoughts right now when anxiety hits? 4. Waiting for a perfect therapeutic alliance. Yes, the alliance matters, but the idea that you must build trust for months before doing anything can delay help. Micro interventions and early symptom relief can often build the alliance through impact. Supervisor to trainee: don't challenge her thinking yet. You haven't built enough trust. Even though the client asked for strategies to stop catastrophic thinking. Alternative statement. Try a gentle intervention now. You might actually build trust by showing her you can help reduce her distress. 5. The codependency catch-all. Codependency is so ill-defined, it can mean everything or nothing. Is it enmeshment, lack of boundaries, fear of abandonment? We need clearer language rooted in specific relational behaviors and psychological constructs. Therapist: It sounds like you're being codependent with your partner. Instead of clarifying if it's boundary issues, fear of conflict, or trauma bonding. Alternative statement: let's identify what keeps you from expressing your desires or taking space when needed. What's your internal dialogue when you feel responsible for their emotions? Start 6. Inner child work as a default. Not every issue stems from childhood. Not every client needs to heal their inner child. This frame can distract from present-day cognitions, behavior, patterns, and values-based goals. Therapist: we need to go back and talk to your inner child before we can work on your current anxiety, even though the client's anxiety began after job loss in adulthood. Alternative statement: is there a childhood link to this anxiety, or is it more about your current fear of being seen as inadequate? 7. Overuse of the term traumatized. Let's be honest, not everything distressing is a trauma. And no, talking about trauma doesn't necessarily re-traumatize. That claim ignores well-established research on exposure-based treatments and narrative processing. Client: I was traumatized when my professor gave me a C. Language borrowed from trauma culture, but not aligned with trauma criteria. Alternative statement: that was clearly upsetting. Let's explore how you processed it. And if it's left an ongoing impact, we should address. Wait. Treat the substance use first. Myth. This old dogma delays effective care. We know from integrated treatment models that people with co-occurring disorders often benefit when we address both at the same time. Clinician: we can't work on your depression until you've been sober for 6 months, even though depressive symptoms may be fueling the substance use. Alternative statement: let's treat both your substance use and depression together. They may be connected, and we don't want one sabotaging the other. Or 9. Gold standard or bust. We love calling something a gold standard, but therapy is not one size fits all. Instead of chasing silver bullets, we need to look at empirically supported treatments for specific conditions, symptoms, and individuals. Clinician: CBT is the gold standard. We'll use it for everything, even when the client presents with complex grief or existential distress that may benefit from integrative approaches. Alternative statement: CBT has strong evidence for certain issues. Let's see how we can use it and consider integrating other tools that fit your experience. 10. Misunderstanding evidence-based. An evidence-based model doesn't mean it's best for every problem. Evidence-based practice means integrating the best research with clinician expertise and patient values, not worshiping a single school of thought. Therapist in training: I only use evidence-based models, like DBT, for everyone, missing the nuance that evidence-based practice is a three-legged stool: research, clinical expertise, and client values. Alternative statement: let's make sure the model we use is evidence-based for your symptoms and fits your learning style and goals. 11. It's all about the relationship. Some models say the therapy relationship is the primary mechanism of change, but the common factors research is clear. It's not just the relationship, it's what kind of relationship. Elements like collaboration, agreement on tasks and goals, and a sense of hope predict outcomes, not warmth alone. Therapist, the healing comes from our relationship. Insight and skills will emerge from that. Neglecting active techniques, symptom relief, or skills training. Alternative statement. Our relationship is very important, but we'll also need to agree on goals, work on change tasks, and measure what's helping. If you found yourself questioning some of these ideas, good. That means you're doing the hard thinking this profession requires. If this video helped you rethink something, please like it, share it, and subscribe to the channel. And if you want to go deeper, consider joining the channel for just $6.99 a month. You'll get access to exclusive member-only training videos, special workshops, early access to new content, and regular discussions on how to integrate REBT with CBT, ACT, trauma work, and more. Thanks for being here, and keep thinking critically. See you in the next video.